Okay. Hello, everyone, and welcome to today's talk by Dr. Prabha Chandra titled Every Breath You Take, the impact of coercion and control by families on the mental health of Indian women. This is part of the colloquium series organized by the Ramalinga Swami Center on Equity and Social Determinants of Health. I'm going to start with just a brief description of the colloquium series so we know what we're trying to accomplish here. Here at the Ramalinga Swami Center, we address the multiple and intersecting dimensions of inequality as they affect health and access to health services. The colloquium series intends to foster conversations around health inequalities, particularly those relating to gender and its intersections with other sources of structural inequality. In the coming months, we hope to invite speakers from different backgrounds, research, policy, advocacy, practice, and that we'll invite them to speak about a range of health concerns and multiple axes of disadvantage. To all our attendees, we are really glad you're here today and hope that you will attend in the future too. I'm just going to introduce Professor Chandra here. Dr. Prabha Chandra is a senior professor of psychiatry and the dean of faculty in behavioral sciences at NIMHANS, Bangalore. Her work focuses on the mental health of women in vulnerable situations, including women facing gender-based violence, women in the perinatal period, and women with mental illness. She is president-elect of the International Association of Women's Mental Health. She is an active researcher with over 320 publications, multiple books, and research grants related to women's mental health. In today's talk, Dr. Chandra will discuss the ways in which psychological violence towards women within families in India influences their mental health. Much of what we know and understand about violence is grounded in the research about intimate partner violence and physical or sexual violence. She takes a different approach by focusing on psychological abuse and coercive control in the family context. This is not an easy topic to study, both for the sensitivity of the topic itself and also because there's a lack of data. There's lack of national level data, and whose multi-country study on violence have not fully succeeded in capturing this dimension of gender-based violence. Dr. Chandra will discuss her findings from the recent Lancet Psychiatry Commission on Intimate Partner Violence and Mental Health, which she's working on right now, as well as the leadership of the Stree Manoraksha project founded by the Ministry of Women and Child Development, which trains staff and counselors in 704 one-stop centers across India in responding to mental health issues related to gender-based violence. We can't think of a better speaker to join us today, so welcome, Dr. Chandra. Please go ahead.
Thank you, Abha, and I thank the colloquium at the Dr. Ramalinga Swami Center for having invited me for this session. I thought hard about what I would like to talk when we started discussing the possibility of my talk. And one of the areas that I felt which is less discussed and not really deliberated on, but has a huge impact on mental health, is one of coercive control. And hence I chose to talk about coercive control as violence towards women, and which is also extremely gendered in its nature. The other reason why I chose to talk about this was even internationally, if you do a sort of, a search, you will find that there isn't enough about coercive control and the impact of that on health or help seeking or indeed mental health. And so this is also to, encourage younger researchers to start working on this topic, because I think it's one of those areas which are not easily studied, because women, as I'll show you, tend to internalize a lot of issues. So let me just start off and also tell you that in addition to my talk about coercive control and its impact on mental health, I'm also going to then sort of move on to some work that we are doing with one-stop centers across the country, where we are training counselors in sensitive care, mental health care of women facing violence, and how we are using reflective methods and reflective pedagogy as a method of encouraging women who are counselors, who are also from the community which the women come from, and where patriarchy is very, very internalized, to start thinking about alternative ways of thinking. So as I start, let me share my screen. And so if you're wondering what the title means, Every Breath You Take, and the impact of coercive and controlling domestic violence on the mental health of Indian women. I want to sort of, start off with the song that a lot of us sing and know. This is the song by the Police, and it was Sting's song, who wrote it. And it's supposed to be, it very often is mistaken for a romantic song, but the lyrics are completely about possessiveness, about control, and about coercion. In fact, Sting himself said that I wonder why people think it's a romantic song, because if you look at the words, it's every breath you take, every move you make, every bond you break, every step you take, I'll be watching you. Every single day, every word you say, every game you play, every night you stay, I'll be watching you. And interestingly, every smile you fake, every claim you stake, and every vow you break, I'll be watching you. So, in fact, Sting himself talked about how, he wrote this song when he was having a breakup, and it was related to control and, not a very nice song. In fact, he himself called it a nasty song. But I think that it's really interesting, and it's paradoxical that a song like this was considered to be romantic, because many times there's a very thin line between coercion and coercive control and somebody really caring for you. And many women, when we talk to them about issues like this, even though they think of it as quite damaging to them, will give it a flavor of romance, or say he likes me so much, he loves me so much, and that's why he's doing it. He cares for me, and that's why he's doing it. He wants to protect me, and that's why he's doing it. So I think it's very important for us to remember that some of these things can be extremely difficult to unravel, nuanced, and a very layered, and hence the assessment also becomes equally important. So to just give you an idea about what is coercive control. So a coercive control is a pattern of violence that is coupled with emotionally abusive intimidation, coercion, and control. It can be coercion or it can be control. And what is interesting is that the regular questionnaires which assess intimate partner violence, the typical psychological, sexual, physical, like Abha mentioned, really don't assess coercive control very well. So the coercion basically means it's structural forms that compel obedience indirectly by monopolizing vital resources, dictating preferred choices, micro-regulating the partner's behavior, limiting her options, and depriving supports which are needed to exercise independent judgment. And control basically isolates a person from their family or friends, exploits them, monitor movements, and restricting access to information and services. And I'll talk a little bit later about some of the studies which have been done and the impact of coercive control on mental health and on several of these other issues. So societies where there is a lot of gender inequity actually exaggerate, where the women have a subordinate position in society. You find that coercive control is much more. And perpetrators often use gender norms to constrain women's mobility, time, spending, and socializing, indicating that, so it's not okay for women in our society to do this, or to go out to work, or to keep going to your mother's house after you get married. So these are very gendered issues which are culturally entrenched and are often used by the perpetrator to exert coercive control. And this becomes normalized to the point where it's very difficult sometimes to differentiate the coercive from the normative. And I think this is something important for us to remember. In fact, Dr. Abha talked a little bit about, the WHO study, multi-country study on violence, which published its data on physical and sexual violence very early on after the study, but waited much, much later to actually publish their psychological violence data, because the data, the prevalence was so varied between all these countries. Sort of emphasizing why the issues like psychological violence are very hard to rate, and women themselves many times do not acknowledge that it's psychological violence. So even though questions are not even in the NFHS, for example, the questions are never, are you facing psychological violence? The questions are, have you been ridiculed, humiliated? Have you been insulted? Have you been put down? But clearly, even if those are the items which are there, women are not able to, recognize some of these as psychological violence, and maybe they don't want to score it because they feel that it's quite normal and it's okay. In fact, what is very surprising that if you look at both NFHS 4 and NFHS 5 data, and you look at the rates of psychological, physical, and sexual violence, you'll find that psychological violence is way less than physical violence, the reported rates, which seems extremely counterintuitive and paradoxical, because you expect that somebody who's going through physical violence is also going through psychological violence. But clearly there are measurement issues here, and I think it's for us academicians to actually advise people who are doing the NFHS surveys to think of ways in which they can recognize psychological violence, and even more so coercive control. So some of the sort of examples, are compelled to do household chores in a particular way, keeping records of expenditure and sort of monitoring every expenditure. So you can have non-violent coercion, which is basically, creating the expectancy for coercive outcomes. So he didn't want me to work. He used my family against me. He would call them and say I did things that I had not done, and they would believe him. Or creating or exploiting vulnerabilities. If you don't do this, you will have no money or possession. So if you leave me, you have nothing. So kind of emphasizing that the person is, completely vulnerable. Wearing down resistance. So even if the woman wanted to escape, how could she do it? She didn't have a job. She didn't go to the store, couldn't drive. So basically trying to create an environment by which the woman finds it very hard to escape this particular situation. So these are non-violent forms of coercion. Surveillance is a very important way of coercion, and it cannot work without surveillance. And abusers often use frequent phone calls to monitor their partner's whereabouts. Third parties are also involved in surveillance. Children are recruited to report their mother's behavior, about who came home, who the woman talked to, when did she use the phone, when did she come back from home, return home. And we sort of, these are some of the examples that women have told us. And men say things like, I used to call a lot to check upon her because I loved her. Or a woman says he would follow me, watch me with binoculars, call me constantly, would show up at work to check where I was. He answered all my phone calls and would not let me talk to my friends. He would question me a lot. So, and so many women who come to us for help actually tell us that they're not allowed to send in messages in their family WhatsApp groups without permission. They're not allowed to make phone calls to friends and family without permission. In fact, a great study, which I will talk a bit later about, but just to give you some idea, where in Mumbai, urban Mumbai, the organization called Sneha, which works with women with domestic violence, is doing a large study looking at mental health and various forms of violence. And they looked at data in a large set of women, urban women from Mumbai, and created a tool to assess coercive control. And it was very interesting that the topmost, coercive actions reported by women included not permitting her to contact her family, not permitting her to work, not permitting her to access health services, and not permitting her to use the phone. So these are, and you can see that all of them are permission. So clearly, the woman needs to take permission, and if she takes permission, she's not allowed to do that. So I think these are some of the ways in which coercive control happens. And we all of us have heard statements from women which such as, he allows me to work, my family allows me to go back to my house. So things like that, or permits me to do that. So there is a level of control which happens at many of these areas. And what is disturbing in the Mumbai study is the fact that a lot of women were not allowed to access health services, because it is felt that by accessing health services, the woman may actually also access other forms of support, and that is perceived as a threat. If she's not allowed to, contact her family members, then that's a perceived that is a decrease in social support. And we know that one of the strongest factors which are protective in terms of our social determinants for mental health is having a good social network and a good social support system. So if through coercive control, a woman's networks are narrowed, she does not have adequate social support, then automatically there is an impact on a woman's mental health. So this is just to give you an idea overall, a little bit about, internalized sort of patriarchy. So these are the rates from NFHS 4 and 5. The NFHS 4 overall rates of domestic violence faced by Indian women was 29.3%. In the 2019-2021 NFHS 5 survey, it's 31.2%. So it's actually increased. And all over the world, this data, 1/3 of women report some form of violence, and that's reflected in our NFHS as well. And if you look at these graphs, which basically show the percentage of women and men who agree that a husband is justified in beating women for at least one reason. I'm showing physical violence figures because that actually is the sort of one of the most severe forms of violence. But if you look at all these figures where the percentage of women, 83.56% of women, 83% of women, 78% of women in so many states actually said that the husband is justified in beating women for at least one reason. And, these are rates of men who justified it. So again, indicating that there is a widely held belief that it's the woman who's mainly responsible for the smooth running of the household, and that any dereliction of her duty towards her in-laws or looking after the house or children merits violence. Now, while we're talking about some of these, this is data from NFHS 4, where the study done by Kanogia and Sivakami Muthuswamy and Saurabh Rai from TISS, which analyzed the NFHS 4 data specifically for coercion. And if you look at this figure, it's a very interesting figure on this side, which basically depicts the prevalence of coercion as an underpinning of physical, emotional, and sexual violence. So one of the things that has been found in many studies across the world is that it's almost like a gateway. Coercive control is like a gateway to physical and emotional and sexual violence. So if you look at these graphs, this graph, the 11% over here is where there's no coercive control. And as the various types of control increase, the number of types of coercive control reported by a woman increase, you find that the rates of physical violence also increase, with the maximum physical violence happening if a woman reports 4 to 6 controlling behaviors. Same goes for emotional violence, same goes for sexual violence. So it looks like coercive control is very often an indicator of one, the risk and the possibility of physical and emotional and sexual violence happening in the family. Also, if you look at prevalence of spousal coercive control using the NFHS 4 data, we still don't have data from NFHS 5, which has been analyzed for coercive control. And I think it's a study that needs to be done. But these are the kind of, control reported by women. Partner jealous if the respondent talks with other men, does not trust the respondent with money, insists on knowing where the person is all the time, does not permit her to meet other friends or family, and accuses respondent of unfaithfulness. So these are the various kinds of coercion which have been reported. Now, one of the things that often happens when I give talks on partner violence and family violence is that there will be two people who will raise their hands and say, but all of this can happen female to male as well. Like, why are we sort of saying that it happens more towards women? To which my response is that if you look at the percentage of violence, or even, physical violence is really much less female to male. The figures are really extremely, indicative of much higher rates of male to female violence. But even in terms of emotional violence, the rates are vastly different. And I think wherever there is a lot of gender inequity, the difference in rates actually becomes even more stark. Having said that, we must also remember that studies which have been done in same-sex couples have also indicated coercive control and found that it impacts mental health very poorly. So what are the predictors of coercive control? And this is again from the NFHS 4 study. Women having 3 or more children are more susceptible. If a woman is not working, that's a strong predictor. A woman's empowerment status threatens men's dominant status. So there's been some disparity on, work, with some studies showing that women who work actually face less control, and some studies and some communities showing that they face more coercive control. Lower education and women from the lowest wealth quintile are at a higher risk. And, like I mentioned earlier, an increase in indicator of coercive control, the proportion of emotional, physical, or sexual IPV increases. What are the partner characteristics? Higher education has been shown to be slightly protective in husbands, but not necessarily so. And what is very interesting is studies have actually indicated that higher education of husbands makes them strategically cleverer to introduce coercive control to ensure there's no evidence against such abusive behavior. So when it happens in such a way that, even the woman is often confused whether there is control or not. And of course, there's a strong relationship between alcohol consumption, which increases the risk of any form of violence, including coercive control. Now, while we're talking about partner characteristics here, we must remember that in India, a lot of the violence happens in a domestic setting. And again, the Mumbai study, which was done recently, showed that while other family members also use coercive control towards women, when the partner was showing coercive control, it had a higher impact on the mental health. And women with a partner-based coercive control showed higher rates of suicidality and common mental disorders compared to coercive control by other family members. So there is clearly something in the partner-related coercive control which seems to be quite damaging to a woman's mental health. So these are some of the NFHS kind of data, with men responding with 7 valid situations as the reason to abuse their wives, arguing, and a lot of times when we see people in the clinics, it's about answering back. If she neglects the children of the house, if she goes out without telling him, and some of these issues. Interestingly, many of these surveys or papers have not entirely addressed reproductive coercion, which is also another form of coercive control. And we need to have much better data on that, about, not being allowed to use contraception, not allowed to have an MTP, or, using other ways of kind of, coercing the woman in all, in reproductive issues. So again, we discussed this, but women from 13 states in the NFHS 5 chose disrespecting in-laws as the most justifying reason for beating, and these are the kind of these are kind of items which are there, which actually are there in many of the surveys which look at coercive control. And some of these are really sad because, treating you like you were helpless or incapable, demanded the final say in decisions, and treating me like an inferior, treating me like a servant. Now, what happens is that if you look at the tools which assess violence, including psychological violence, they they use the terms humiliating, ridiculing, insulting. But maybe women need more explanation, and maybe things like treating her like an inferior, treating her like a servant, treating her like she was helpless or incapable. These are things that probably women seem to understand more than some of the other items. So some idea about differences between psychological abuse and coercive control. So like I mentioned, in psychological abuse, it's about insulting, belittling, intimidation, threats, the threats of destroying things as to take away children. Whereas coercive behavior is that, the belief that one can and will punish another for non-compliance and isolating a person, and all the other areas that we just discussed. These are some of the measures which are available to assess coercive control. So while many of these are quite good, I think that for countries like India, we need tools which are more cultural specific, and we don't seem to have too many of those. Like I mentioned, the Sneha study, created a tool which was quite useful, and we really need to have better tools which will not allowing the movement to go to her maternal family is something that is important. I was reading about this culture, a practice called bandage, which is practiced in Bundelkhand, where if a woman has been having repeated in miscarriages or is not conceiving or is not getting pregnant, then for a whole year she's not allowed to visit anybody, not allowed to meet people, not allowed to use the phone, not allowed to use makeup. So there may be very ritualistic, culturally accepted kinds of coercive control, which we may really not be capturing with tools from the West. These are just some tools I thought I would show. So this is one tool which we are using in some of our studies, which is called the ICMR Domestic Violence Questionnaire. And if you can see, there are some items on coercive control, like threatening to send you back to your parents. So that's another thing, I'll send you back to your parental home if you misbehave. It's almost like a punishment. It's almost like treating a woman like a child, like giving time out, or sending to the parents' home, showing indifference, depriving her of social rights, non-involvement in decision making, and restriction in mobility. So there are tools which are available, which are slightly nuanced, but they also use it under the term psychological abuse. And it is important to kind of differentiate it. And the advantage of a tool like this, which it also looks at how long it happened and who did it in the family. So, and whether the woman was subjected to that during pregnancy, because again, we know that partner violence or control during pregnancy can have an impact on poor mental health. This was a very interesting study, which used social media and used the hashtag maybe he doesn't hit you. And because public intimate partner violence discourses emphasize physical violence, and then the Twitter generated a public conversation about abuse beyond physical IPV. And because survivors often struggle to name abuse which is happening in their daily lives. And what was interesting was that this came up as a huge issue, and many women wrote back that this was true for them. They also emphasized that it does happen even in same-sex relationships, and to sort of widen the scope of trying to assess intimate partner violence beyond physical or other kinds of sexual violence. So my role as a mental health professional is also to see how coercive control actually impacts survivors. So if you look at this, it challenges the survivor's autonomy, it depletes support system, like I mentioned, it results in distressful affective responses, it's a threat to liberty, impedes self-decision making. And I found this very often, women tend to start doubting themselves and their abilities. It compromises the capacity for a woman to be independent, takes away the sense of equality. And also, there is a certain kind of threat appraisal where a woman finds it very hard to have a cognitive response to coercion, and after some time her threat appraisal actually comes down with her accepting everything that is going around her. In this study, which was done very recently and published in 2021, looked at the impact of coercive control. And it found that even if you control for physical violence, sexual violence, and emotional violence, coercive control is associated independently with mental health concerns. And partners had 3 to 8 times more likely to experience, physical, sexual, or emotional IPV. There was a higher risk of common mental health disorders like anxiety, depression, suicidal ideation, and PTSD. So coercive control by itself can actually, lead to many of the mental health problems, and hence it really needs addressing, both in the GBV community, in people who work with gender-based violence, but also among mental health professionals, because I don't think that there is enough understanding even among mental health professionals about the impact of this. Now, I do want to emphasize here that while we talk about all the emotional impact and mental health impact it has on women, we must remember that there are also acts of resistance. And women are, though women in media and, sort of, if we use a very victim kind of a framework, women are identified or depicted as being passive, but women in abusive relationships often resist their partner's abuse. And it's very important that when we train counselors, when we train mental health professionals, or we talk to women, we must remember that the intimate partner violence story should be retold from the perspective of the woman who talks or demonstrates strength and resistance in a situation, because I think that is also something that needs to be told, and resistance can be both overt and covert. So women in abusive relationships can retain a sense of self, and that's how they protect their mental health, by entering what Stark calls safety zones. So safety zones can be considered concrete objects as well as abstract thoughts. So it could be a physical, like a movement, a gesture, a physical contact with a person, sometimes a pet, a verbal, saying something, yelling, shouting, making sounds, other types of action, like taking a picture with a cell phone when something like that is happening, texting a friend, or a help, calling a helpline, flickering lights to attract someone's attention. Sometimes just a thought, imagining oneself in a safe place. So I think when we work with women who face violence, very important for us to ask them what are the things they are doing to actually protect themselves psychologically. And many of them will tell you things that they do to support themselves. And these are some of the things that women have told us. I sleep on a separate bed. I continue to maintain eye contact with the perpetrator. I don't look down. I make sure I go take extra care of myself through shopping or going to the parlor or eating good food. I choose to stand strong even though I'm being insulted. I keep collecting evidence against him, makes me feel in control. I do something they won't like in a family. So, and we listen to this story very often, that a family member will say, she answers back, she doesn't listen, she's very argumentative, and the women will tell us that, I have to do something, otherwise I'm not going to retain my sense of self. So these are ways in which women actually also resist. It could be resistance through thoughts. I think about ways I could hurt him back. I think about what would life be if I separate. I think about an imaginary friend. He should be ashamed. I actively try and think about ways to protect myself. I use imagination. So these are ways in which they use thoughts. Resistance through reaching out. And while in our country, most women reach out for non-formal sources of help, including domestic violence shelters, but they may not necessarily go to the police or use the government system very much. But talking to friends, family, including sometimes talking to the husband's family or the in-laws' families, writing letters to themselves, finding a safe space, going for therapy, contacting a helpline, safety bag. These are things that women themselves do. And these are things that women have told us how they continue to resist and retain their sense of self. So I think while those of us who work in the space, we do recognize the whole impact that violence has on women, it's also important that we highlight resistance, because other women learn from it. So resistance narratives make resistance accessible to others. it reconstructs a sense of agency. And sharing these narratives implies that resistance is possible. It builds hope, reauthors stories of victimization and helplessness, and rebuilds the story with a lens of empowerment. And I think this is something that we often forget, and hence using this in pedagogy, in training people, in working with women who are facing violence becomes important. So I'm just going to segue a little bit into the second part of the talk, which is, for the next 10 minutes or so, which basically talks a little bit about all this learning that we have from our surveys, from our research. How do we then use it to help people who are working with women facing violence in supporting their mental health? One of the things that happened, I think we all know, during the pandemic was increase in domestic violence, which became a shadow pandemic. There was also an increase simultaneously in mental health problems and an increase in calls to domestic helplines. And of course, there were huge challenges to providing support because of the various reasons we know about lockdown, and women who called up the domestic violence helplines and then only had to be reliant on tele support, which was also a challenge because people were not trained in providing completely tele support when the woman was still at home. So the huge challenges: how do we not increase risk? So at this point, we started the project Stree Manuraksha, a background that we interviewed one-stop center counselors from across Karnataka, all 31 districts, and talked to them about what challenges they were facing, what are the kind of situations they were coming across during the pandemic. And this was a qualitative study, and they told us some important key things. One is that they said mental health issues are huge and we are not trained to manage mental health issues. That was one big thing. Second thing they mentioned was that they were not very comfortable doing tele support. And we also recognize that many of them had their own myths and misconceptions about what counseling was when it came to gender-based violence. And not all of them were using a feminist lens or a lens which took into account gender inequity in their intervention. So we approached the Ministry of Women and Child Development and said that we would like to train all the one-stop centers across the country in trauma-informed mental health care. And that's how Stree Manuraksha started. So just to give you, those of you, I'm sure many of you who logged in are aware of this, of the one-stop centers, but just to give you an idea that there are 704 functional one-stop centers across India, including in Andaman and Nicobar and the Northeast and Jammu and Kashmir. And in the one-stop center, women are provided medical assistance, you can lodge complaint, you're given support, psychosocial, there's provision for legal aid, temporary shelter, and in some one-stop centers, there's video conferencing facility, and they have staffing of a center administrator, caseworker, counselor, a police facilitation officer, paralegal person, visiting medical personnel, and a multipurpose worker. Now, while this looks fantastic on paper, there are huge challenges about managing, about staffing, about training, and that we came to know when we started doing the training. But and several audits have actually discussed this about the fact that even though there are one-stop centers, they may not be working entirely optimally, but they exist as a way of approaching women who face violence. This is one of the one-stop centers which has been created in Bangalore. This is called the Nirbhaya Sakhi One-Stop Center, which is there in the Majestic area, and it's really done up well. But this is the new center. And prior to this, the one-stop center in Bangalore, for example, was in a very remote, dilapidated house, which no woman would ever be able to find. And one of the, senior police personnel, she actually, took the initiative and said that no woman would be able to find this place, easily, and moved it to a much more friendly space. And we have been providing training for this group as well. So, but just to give you an idea that not all of them look so beautiful, but they're fairly well equipped and managed. So we then, during the pandemic, actually visited the Bangalore Center, the Tumkur Center, interacted with the one-stop center staff. And one of the things we found and realized that it was not enough for us to train counselors. This is my team, interacting with the staff in the one-stop centers in Tumkur, this one, and in Hoskote, I think, yeah. And so one of the things we recognized that it was not enough to train only the counselors, because when women come into a service, there are several people who meet them. So there's the security, there is the office attendant, there is the cleaner. So we decided that trauma-informed care should start from the doorstep, and it should be a systemic response. It cannot be only the counselor who's doing it. While we were doing the training, we also recognized there was a lot of internalized systemic misogyny and ideas about domestic violence and gender-based violence, and we recognized that we needed to handle it at every level of the staffing there. And so that's when we decided to have two kinds of training, a basic training and a more advanced training. This is just some snapshot data from our pre-assess a need survey. If you see, majority of them had, the counselors had no formal training. Some of them had attended lectures. None of them had done any any counseling or certificate course, and a very few of them had actually attended any skill-based training workshop. So they were just doing based on an SOP. And even though their intent was very good, and they were quite knowledgeable about the Domestic Violence Act and some of the legal procedures, the mental health aspect was actually very poor, and a large number of them were actually handling on a daily basis this high load of women coming to them. Most of them felt they were confident in asking about questions, but they were least confident in identifying signs of mental illness, anxiety, depression, and majority of them actually said they were not at all confident about women who disclose self-harm or suicidal thoughts. And we know that from our data earlier that women who face violence have high risks of suicidality. So it was very important for us to do this training. Personal beliefs, and this is where I talked about systemic misogyny. 30% agree that violence was part of any relationship. 20% said that, and these are counselors, that the women had done something to bring violence into the relationship, and 10% agreed a lot, but most of them kind of were in the or had some ideas that for the sake of holding the family together, the woman should tolerate violence. Now, when people have such strong personal beliefs, and like I mentioned earlier, most of them came from the community, it was very important for us to address this, and hence the pedagogy that we used had to be highly reflective and not at all didactic. And so we used several methodologies, which we can discuss later, to to focus on some of these. Lots of barriers, like I mentioned earlier, and so we had these two types of training: the basic training for all the OSC staff and a certificate course for counselors who support women directly. And some of these internalized ideas, sometimes women are lying and faking. We have to find out the truth. It's a woman's mistake if she goes out to a party in the night and gets sexually assaulted. And this is from counselors in one-stop centers where women are coming for support. Women leaving their homes late night for an emergency or a job is acceptable, but when they do for recreational purposes, it may be risky. Again, something about women wearing, clothes. If there's extramarital relationship, then violence is acceptable. Though the woman clearly wants help leaving the abusive relationship, I believe that as a counselor, we should always work to keep the family intact and not split it apart. And this theme kept coming again and again, so much so that a lot of, all the one-stop centers actually would call the partner and do couple counseling, though we know that couple counseling is actually contraindicated when there is violence in a relationship. So as health professionals, I think it's very important for us to recognize some of these. And like I mentioned, reproductive violence, which came up again in the training, needs to be acknowledged. And and so to just go on, these were some of the modules we used for mental health support for women. And we did a lot of work on self-care for counselors, because we also recognized that counselors themselves were going through violence, some of them, and that was important. So these are some of the as part of the curriculum that we used, and we can discuss this a little later. A lot of the training was through Zoom. It was online training, breakout rooms, lots of case vignettes, personal testimonies, which were very, very strong. And the counselors actually liked the personal testimonies, role plays, and extremely brief didactics. And this is the team actually conducting, for various states, the online counseling, online training. We used a lot of reflective exercises, including how do you work with partners. And for this, we really have to thank Sehat. We did a lot of brainstorming with their team in Mumbai because the counselors were anyway calling the partners, and a lot of coercive control was happening. So how do you engage the partners without letting the woman lose agency? How do you make the partner be a little bit more accountable, rather than it becoming a session where he says, oh, she has to listen to me, or she doesn't listen to me, and that is why I'm doing what I'm doing. So I think the important thing was to sort of help the survivors regain control over their lives, and for using a strength-based approach, where we were talking more about personal strengths of women and giving them agency, rather than making them think of themselves as victims. These are some of the feedbacks which we got from various one-stop centers, which was quite good. And they really liked the case-based discussions, suicide risk assessment, and of course, many of them said they liked the meeting with the perpetrator. So as of now, we have finished, we have completed training for 623, OSCs. Total number of training hours, almost 1,300 as of today. We have trained 3,280 participants in so many states, and we're trying to create a band of lead trainers in each state, so that it can be this training can be sustainable. While I just want to end with the fact that even though we say that counselors have so much of internalized misogyny, I think mental health professionals are no better. We have such immense amount of training in many of these areas. But if you look at studies which have been done, and this study has been done in the UK, where mental health professionals, including psychiatrists and psychologists, said that they lacked expertise and knowledge about domestic violence. They found it too complex an issue. They felt that inquiry was not part of their role, not a priority. Questioning if there's evidence that asking is helpful, and also saying that they had personal discomfort. They felt there's no indication of violence, and dominance of the medical diagnostic model, and of course, gender and cultural issues. And this was the background in which the Lancet Psychiatry actually, we had a commission, and it's a wonderful, document which actually lays down criteria by which mental health professionals need to address this problem at all levels, at all touch points. This is a study from NIMHANS, where we think we train our residents very well. And how frequently have women spontaneously disclosed intimate partner to you? Only occasionally, 65% of them, 69% of them said only occasionally. How often do you check for IPV? Or 59% that they said that they do it only occasionally. So, and many of them said not at all. So it's really worrying when we know the strong impact of partner violence on mental health. And when we ask them what were the barriers, if you look at the red bars, lack of training and supervision, lack of privacy, concerns about victim safety, lack of knowledge about available resources. And I think this is where even the Lancet Commission talks about a strong liaison between GBV services, shelters, domestic violence services, and mental health services. And I think that's completely lacking. We are working in silos. Very important for us to integrate. We have started doing it. Like some of us work very closely, and the one-stop center training is an example of that. That's coming from mental health. But I think there needs to be much more. And what was worrying was this whole therapeutic nihilism or helplessness in a large number of residents who said nothing can really be done. This is my team, this of Sri Manораksha, and I think we've had lots of learnings by learning about coercive control, psychological violence, doing our research. And the learnings are basically, one is that we need to listen to women's voices, value lived experience, and also focus on use a very agency-based lens rather than an entirely victim-based lens. This is a tree in front of my room, and I found this little kite hanging there in the shackles of all those branches, and it kind of reminded me of the shackles that we have as teams. And we had to work a lot on our own team dynamics and our own internalized patriarchy and misogyny before starting the training program. So it's very important for teams to also constantly question themselves and break free. These are some resources. This is the World Psychiatric Association curriculum for mental health care providers on violence against women. It's been written by a colleague of mine, Donna Stewart, and myself. It's recently been revised in 2020, December, during the pandemic, and it's a huge, beautiful resource for mental health professionals. It's open access for anyone. This is again a very nice resource from the UK, which is a UKRI resource on violence, abuse, and mental health, and it has a lot of material for all of us to learn, including videos. These are some WHO and the McMaster very nice pedagogical methods which are available. And finally, I want to acknowledge my teams, Sri Manораksha, Dr. Madhuri, Dr. Parul, Devanshi, the ministry, the NIMHANS Digital Academy. This is the Sri Manораksha website, which has a lot of resources in different languages. So I must mention that we actually train people in the languages of their choice, and including in Telugu, Gujarati, and Bengali, not Bengali, Assamese, and Uriya. And so we had a range of trainers who could do that. So this is the website for those of you who want to use any of these resources. All of them are available, including posters that can be used in health settings to encourage women to talk about psychological violence and control. And this is my Twitter handle. So I'm going to end here and take any questions. Thank you.